What's going on, everybody? Happy Thursday and welcome to another episode here on I've Got 10, and very excited to continue our podcast series with the Dental Consultant Connection team. And today, very, very honored, as you can see on the screen, we have Christine Taxin. I don't know how many of you out there have heard about, are wondering about, are trying to learn more about medical billing, but it is a true honor to bring Christine to I've Got 10 because this is what she does. She lives it, she breathes it, and we're very, very excited to have her on the podcast today. How you doing, Christine?
I'm great, John. How are you?
I'm doing wonderful,
I'm so excited to be with you today. It's always a joy.
Well, thank you so much. You have that nice, I don't know what you would call that behind you. It looks like
my Chinese screen.
The Chinese screen. Yeah, I like that. Perfect. Mm-hmm. All right. So what we're going to do today, Christine and I were talking a little bit beforehand, is that there's so much in the world of medical billing, but we thought that we would have her talk a little bit about the why, just a little basic summary on that. And then she actually is going to share 3 tips on some specific procedures and or some changes with medical and dental billing that we thought would be super helpful. So Christine, the floor is yours.
Well, thank you, John. I'm really grateful to have this opportunity because, you know, the people that do all the work in the office, the billers, the front desk, they get the least amount of training, and I want to just keep getting them to the point of career-orientated people. And one of the things that I'm seeing is that we're getting more and more dental codes that are no longer procedures that are covered under dental, because we're moving into the medical world. I mean, diabetic blood testing, finger prick in a dental office. Unbelievable. And taking care of patients before they go for chemotherapy so they don't lose their teeth. So there's so many systemic issues that we now know are connected to the medical world that the colleges, the dental school colleges, are adding in medical training into the dental community as they're in school. So one of the things that I taught at, and one of the places, is Harvard University. Harvard University's 4-year program for the dental school now includes 2 years with the medical school, and vice versa. The medical school works with the dental school. And the reason is that we know that if the oral cavity has an active infection, it is not just staying there. Saliva, swallowing, eating, all puts it through your whole body, and it affects our whole body. So we know patients with diabetes are sicker if they have an oral issue. And we know that if we could keep their oral cavity clean and free of infection, that they could stay healthier. We can't cure diabetes, but we could help these patients stay healthier. So if diabetes can cause you to lose your sight or have an amputation, what makes us think that we don't have a responsibility? So there's a big component here of health and the oral cavity that prevents issues with the body. And so a lot of codes that are coming out in the dental world are there as a place mark, but they won't get covered by many dental plans because medical already covers it. So it's just an amazing process to be watching, John. It's really amazing. So one of the things that we've been doing for a long time is oral cancer screening, right? And we buy Velscope and we get different topics, different things, and we complained it wasn't covered. Well, you could bill it to medical. And technically, if you read a patient's contract, a lot of them have coverage in there for once a year for oral cancer screening, just like diabetic screening or wellness screening or any of those things. So we really need to learn about those issues so we could help our patients stay healthy. Because a lot of them refuse treatment because they don't understand how important it is, because they feel like, well, if dental coverage is not paying for it, how important could it be?
Right.
And that's a fallacy.
Yeah, and I think what's interesting is that when you think about the oral systemic link, like what you were talking about, and the movement that's been going on for many years, quite frankly, not too many people recognize. I know you do, Christine, that this has really been going on probably since the early 80s. It's really, fortunately, got a lot of momentum here in the last 3 to 5 years. But now all of a sudden, there's more people excited about it. Like you said, patients are asking, dental practices are talking about it. But then you've got the billing piece, right? Then you've got the whole insurance piece. And I know that's the world that you live in. So I would love to have you share some specific examples, of procedures or drugs or whatever the case may be, that you can share with everybody that would be helpful for them to know how they could start to go down this path and do more along the medical billing side.
Okay. Well, one of the newest codes that came out in January is for an opioid drug that is inserted in the oral cavity when there's a surgical extraction. And what that's going to do is the opioid does not spread through the entire body. So there's no chance of that person becoming addicted to opioids. So that's the number one key for the reason this is going to be in dental. The thing about it is it's been used in medical, and even Medicare has approved it as a payable procedure. So billing it to dental, I only know, John, of 2 dental insurances that are going to cover it at this point. One is some of the Aetnas. You have to remember that Aetna is a big company and has different policies, and Dominion Health. So I would recommend that offices that are going to be using this drug, especially oral surgeons or doctors that are doing more surgical procedures, learn how to bill this in the medical world, because the drug is expensive. So if the doctor is spending the money purchasing that drug and then has to ask a patient for $300 out of pocket to do a surgical extraction, they're not going to get anywhere as to where we want to go as far as opioids.
Right.
So I would really encourage them to look into that. And I have samples of EOBs on the medical end that I would be happy to share with anybody that wants to learn about it, to see and show them it is a covered procedure. The next big topic is the CBCT scan. I mean, I've worked with hundreds of practices across the country, ortho, especially endo now, which is standard of care in the endo world, on taking a 3-dimensional picture. And dental does not cover it. There's only one plan I know of that covers it. And most people that need it are having specialty work. So if you have a $1,500 maximum dental plan, and you're going to have, surgical extractions, and you take a CBCT scan, you're using up $500 out of that $1,500. So the patient's paying no matter what. If you bill it to medical, you are going to get paid. And one of the recommendations I give to practices that have it is to contact a company that I work with on what their state rules are and whether or not they need to be an accredited facility, so that now they can not only bill it for their own patients, but they can actually use their CBCT scan as another business and have it credentialed, advertise with it, and be able to take pictures of patients for other doctors and just have them sign a consent that you're not reading it and you're still billing for taking it. So there's a lot of ways of, making that work. And when I see offices not billing it or charging the patient $100 for this, that's a loss of income. You can't even clear your monthly payment.
Right.
And doctors have said, well, I get a case out of it. That's great, but you should get a case and make money.
Right.
On all the procedures you do, not just some of the procedures that you do. We're not in business to give it away. We're in business to pay our teams and all the other expenses that have to come from owning a business. So That is me. And then finally, a lot of EOBs are coming back to offices, and I get calls every day. Well, what do I do? And they tell me I have to bill medical first for a bone graft or a surgical extraction. And that means that they're not willing to pay for surgical procedures at this point if the patient has an active medical plan, because those are considered surgical procedures. So my feeling is, why are we billing incidental, waiting 2 weeks to get an EOB that's telling us to bill medical? And if you're in network, now you're stuck with that in-network fee of dental when you could go straight to medical. So there's a lot of benefit in learning this in today's world. I mean, just growing faster than we could imagine. So that's my tip.
Yeah, and anything else on the bone grafting, or any other final details on that? Or
well, with the bone grafting, there's several different types of grafts. You know, there's a graft when you extract and you place a graft immediately. There's grafts when you're placing implants, and there's different types of grafts, whether it's purchased graft material or bone from the hip, where a lot of big implant doctors are using the patient's own bone. So you have to know how to bill that. You have to be able to understand it. But, you know, it's so funny, because if you're doing an implant with a bone graft and you're billing under dental, there's probably 16 different dental codes for an implant and different codes for an implant, a bone graft. And in the medical world, there's only 2 codes for implants. And then you could just match up the type of bone that your doctor uses and keep that 1 or 2 bone grafting material in as a reference point and not have to worry about all of the bone grafts. So it's truly, you know, sometimes a little bit easier to bill medical than people really think.
Right.
And bone grafts pay anywhere between $300 to $600, according to the type, the placement, and the reason for doing it.
Yeah, excellent.
So
Christine, yeah, I mean, it's so interesting. Every time I hear you speak, I've had the opportunity to be with you a couple of times, and it's one of those things where what I love with what you're doing is it's not just the generality to tell people, hey, you know, you can do this, you know, more and more people should do this. You're offering people specific examples of what they're dealing with in their practice every day. And as you know, there are a lot of dental practices across the country that are dealing with wanting to help patients get their care done, and then, you know, having to have that dreaded conversation, your dental insurance will only cover so much. And right. I'm always inspired when I speak with you, because I think that by learning more about this and by asking those questions or kind of knowing the details of it, the most important thing, as you know, is the amount of patients that we're going to be able to help get some of that care done that maybe financially they didn't think they could do before. And to your point, also get the practices reimbursed, you know, for the procedures and the time that they're working through to do some of these more difficult procedures, especially if there is some sort of medical connection there. So, you know, big thank you to that.
Well, thank you. And one of the things I just want to tell the audience that I find interesting is the big stopgap is, the deductibles are so large. And what I challenge the audience to do is to take a case, a $10,000 case, let's say, and how much would they get from dental? Well, the most they're going to get is $1,500. So that means the patient has to lay out the balance. But I have medical insurance, and medical's deductible is $3,000. And then the balance of the case is paid even at 80%. So the patient's benefit here is much higher, where, yeah, they have to pay that $3,000 up front, but the patient is going to spend less money up front than they would if they only go by dental.
Right.
So I want to say that when you look at the two, look at the case, look at the amount of money that you would get reimbursed, and then make a decision on how do you want to help this patient maximize their benefits. Mm-hmm. And what's the best way for this patient to maximize their benefits?
Yep.
So you're going to still make the 10, and the patient's still going to want the treatment, but they're going to be easier to convert on doing that $10,000 case if they're only laying out 5,000,
right,
not 8,000.
Exactly. Yep. Well,
So,
I wanted to, I put up on the screen for everybody. You can learn so much about Christine and what she's doing and the Dental Consultant Connection group. Christine has her own page there on the website where you can learn more about her. You can certainly reach out to her. And Christine had asked me, before we got started, there's so much information she could talk about. She's like, John, I just want to make sure that I just cover some quick points because I could talk about this forever. You did a great job. You were very concise, very to the point. And I know we could certainly go on forever, but it's always a pleasure. And again, I want to, say thank you. And for all of you out there that want to learn more about this, seriously, reach out to Christine. Links to Success is some stuff that she's doing there. And of course, a lot of the work that she's doing with Robin Morrison over at DCC. So Christine, anything in closing as we leave today's episode?
Well, if you're interested in learning how to bill medical, one of the things they could do is join my dental school website and ask some questions on the forum. That's what I offer. So you don't have to pay. You could just post a question. If you're interested, there's many options. And one of the big things that I do with Robin almost monthly, where I get a call from Robin on auditing. Mm-hmm. And I just want to bring that out. When you do an internal audit, you should do it before you get asked from a company. Once you're asked, it's going to cost you more. Yeah. If you do an audit in good faith and do whatever needs to be done to correct the issues, they're going to be a lot more lenient on the offices. But don't take that you've never been audited, you don't participate with insurance. Why would they do? Everybody, whether you participate or not, is involved in audits today. In fact, companies have a schedule of where they're going to be every 3 months. So they pick on areas, and that's every company, not just Medicare and Medicaid, right? But every dental company and every medical company. So it's a more and more prevalent situation, and it doesn't matter whether you bill dental, medical, or both. Right. Your office will eventually have an audit. Yep. So do it before. And that's what Robin and I are so intent on. And the benefit of me is that I bill both. Right. And I know what documentation needs to be and all of that. So I'm asking them, learn how to do an internal audit and protect your business. Yep. Because that's the most important commodity we all have is our businesses.
Absolutely. Well, thanks again, Christine. And for anybody that watches this, please would love to have you share this with your network. We want as many people out there in dental practices around the country to learn more about what you can do on the medical side, see how Christine's a resource, see how Robin's team's a resource. So please share, let everybody know. And until next week, Christine, have an awesome week.
You too, John. Bye. Bye, everybody.